You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network.
We have an aging population taking more medications than ever before. On this podcast, I will interview experts in geriatric medicine to gain insight so we can provide optimal care to patients in their golden years. I'm your host, Dr. Tamara Ruggles, and this is the Geriatric Pharmacy Focus. Welcome to the Geriatric Pharmacy Focus. I am your host, Dr. Tamara Ruggles. I have a fascinating episode for you today on cholesterol disturbances in the brain of those with Alzheimer's disease. So a few weeks ago, I posted on LinkedIn about my dad, who is 76 and has been healthy, never really taken a prescription medication other than for the occasional infection his entire life, and has had a normal lipid panel his entire life, yet had a coronary artery calcium score greater than 500. So after that post, my guest today, Josh, reached out and shared a few excerpts from his books. He has two of them, The Home Security System and The Lipid Neighborhood. He's got a really interesting background as a physical therapist, an Ivy League grad, a collegiate track athlete, and also done some PhD work in lipid disturbances and Alzheimer's. So with nearly 7 million Americans living with Alzheimer's, and that number projected to grow to nearly 13 million by 2050, I'm excited to visit with Josh today about Alzheimer's and how lipid disturbances may be contributing. So welcome, Josh, to the podcast. And if you could just start by telling us a bit about your background and how you became interested in lipids and Alzheimer's.
Yeah, thank you so much for having me. Anytime you can get Dr. Dayspring on the podcast, that's a riot. Any of us in the lipid space have learned so much from him over the years, and I think he's helped to ignite my fire and my passion for learning all these biochemical pathways, but more importantly, shifting our paradigm from reactionary to prevention. And so anyway, so my background, it is unique, I think. And so if there's anybody else with an identical background, I would love to meet that person, because my first doctorate was actually in physical therapy. So I am a physical therapist as well, among many other titles, but that was my first doctorate. And, you know, I firmly believe that God uses various events, even hard events, to catalyze what we're really supposed to do when we grow up. And I got really, really sick, actually, when I was in grad school the first time, and a myriad of endocrinological disturbances. And it actually made me fall in love with endocrinology and biochemistry and all these things, because I was like, wow, this stuff is really interesting. And so anyway, long story short, I finished PT school, practiced as a physical therapist for years, very grateful, very blessed to be involved in people's lives in the rehab realm. But there was never any sense of finality that I was done with school, because I kind of like school. It's an expensive habit. So that's my,
Yes,
one of my wife is. Yeah, she's encouraged me to, pick up some other hobbies. So that's why I wrote a book. And actually my book that you mentioned, The Home Security System and the Lipid Neighborhood, that releases February 18th. And so, put that on your, on your calendar there. So it should be a fun time. But anyway, so I actually went back to PA school because I figured, I was like, okay, well, I think the quickest means to my end to try to save the world from all sorts of metabolic derangements is going to go to PA school. And so I went through the Yale School of Medicine. It was fantastic, had a wonderful time there. And then I actually ended up practicing in endocrinology and at a metabolic clinic for several years. And my passion for lipids was ignited in a kind of strange way. I wish I had a really good, humanitarian reason for getting into lipids. But in reality, I was sitting there on a cold January day and I had a patient cancel. And I'm always reading stuff. And I pulled up this article and it had this just obnoxiously condescending title, something like Basics of Lipoproteins. And I'm like, okay, come on. I'm pretty good at biochemistry. How hard can this stuff be? And so I read this article that was supposed to be rudimentary. And I really didn't understand hardly any of it, and it made me mad. And so anyway, I was like, well, that's unacceptable, given that this is incredibly important and incredibly relevant to atherosclerosis and coronary disease, which is, the number one killer of people across the world. So I was like, well, this is probably worth learning. And so I devoted myself to learning all this stuff, and that's really what created this monster, I suppose. And I became a clinical lipid specialist. Started seeing people and patients for some of these other, lipid disorders, lysosomal acid lipase deficiency every now and then, some familial chylomicronemia syndrome, and a lot of people that just had events, unfortunately, and we were trying to get things under control to make sure that they wouldn't have recurrent events. And so anyway, so that's how it kind of happened. And then I transitioned to a role in industry a few years ago as a medical science liaison. And nothing we're going to talk about today has any relevance to Amgen. This is all my own opinions, my own perspectives, and that's my caveat here. So we can have some unadulterated fun talking about all the wonderful things. And I, on the side, I was working on a PhD this whole time in lipid disturbances and Alzheimer's, and finished that up. And there's all sorts of stuff that we're going to talk about today, and I'm excited to do so.
Oh, that's amazing. What a background. Yeah. School is expensive, but it is so fun to keep learning. I am often tempted to go back myself, but my husband so kindly reminds me that's probably not a good idea at this point in our lives. So let's start. Maybe you could start with just explaining your framework for lipids and cardiovascular risk below the brain first, and then maybe we'll get into the lipids in the brain next.
Yeah, I think that's a wonderful idea, just because having appropriate context is critical to start to make some sense of the litany of factors that influence both cardiac health and brain health. And in a lot of ways, what's good for the heart is good for the brain, but there are definitely some quirks and some idiosyncrasies that happen in the central nervous system. But for me, and this is a lot of what my book's about, is for everybody who doesn't want to have heart attacks, strokes, and dementia, I want you to have a great home security system, and I want you to live in a safe lipid neighborhood. Your home security system has 4 basic pillars: normal blood sugar, normal blood pressure, keep inflammation low, and don't smoke or do drugs. Those are bad. But then your lipid neighborhood is your cholesterol panel, because every ApoB particle, the majority of those being LDL, are potentially criminals that can get into your neighborhood. And then the LP(a) particles are the felons, because per particle, they're about 6.5 times as atherogenic as your run-of-the-mill LDL particle. That's a genetic factor that has been gaining awareness that everybody should be checked at least once in a lifetime. So how's your home security system? We have many ways of measuring that. How's your blood sugar? How's your blood pressure? Are your inflammatory markers up? Are you smoking? Probably should stop, But, people don't live on paper with their lipid panel. And you mentioned your dad had a, relatively normal lipid panel, or it was said to be normal. Well, got plaque, get a CAC, which is the colonoscopy of the heart without the nasty pregame show. And I'm really glad that your dad got that. I'm a huge fan of coronary artery calcium scores, because it shows, hey, have you been broken into, right? And if you have been broken into, if your physiologic dwelling has been compromised, well, what are we going to do about it? Do you want to keep living in the same rough neighborhood where you got broken into? Or do we have the option of moving you to a nice, safe, gated community with fewer criminals? And we do. And so that's really the preventive approach. And yes, CAC isn't a perfect score, but it's a great screen, right? And it's similar to me to a colonoscopy. When you go and you get a colonoscopy, I mean, it ruins your social life temporarily, but if you have a polyp or two, they don't wait around for you to just get colon cancer, right? No, they take them out, and then you check back at, regular intervals. Well, with a CAC, if you have an elevated score, well, do we just wait around for you to have an event? Probably ought to not do that. And we have ways to mitigate that risk. And so anyway, so I'm a big fan of prevention and helping people make sense of the purpose of cholesterol and the purpose of lipoproteins. Because really the purpose of any of these lipoproteins that can be criminals is not to ruin your life or give you heart disease. They're basically mailmen, right? So their job is to deliver the mail, primarily triglycerides, and go home at the end of the day, which is the liver. All right, well, most mailmen aren't bad dudes, right? But if that mailman, gets lost along the way, instead of delivering the mail, runs his truck into your arterial wall, that's a bad mailman, and you've got a corrupt workforce. And so we need to do something about that. And so really a lot of my book, I use a lot of metaphors. I use a lot of catchphrases and things, because one of my goals has always been to walk with kings, but never lose the common touch. And lipids get so complicated, so esoteric. I love them. I learn things every single day. It's wonderful. And it's a beautiful, beautiful privilege to explore all these wonderful, wonderful pathways. But at the same time, if I can't communicate the things that hopefully I understand in a relatable manner, then I'm no good. And so that's why I use a lot of these things. And there's, pictures and graphics and all sorts of things in my book that hopefully helps us make better sense of the overall factors that lead to heart attack, strokes, and dementia, how to mitigate those risks, and also to make some sense of normal physiology at the same time.
Yeah, that's amazing, because I agree that lipids, I love Dr. Dayspring so much. He's so knowledgeable about lipids, just like you are. But sometimes reading through his stuff, I get a little bit lost because I don't have a background in lipids. And, in pharmacy school, it was, LDL, HDL, just the basics. We didn't really go beyond that. In fact, I didn't really know about lipoprotein little a, apolipoprotein B until Dr. Dayspring, which, by the way, my dad did have checked, but his results aren't back yet. I'm anxious to hear about that. But thank you for bringing this to light and also making it easier for us to understand so that we can understand it, but also better explain it to our own patients who, it is hard to explain these things to our patients without getting geeked out in different terms or being able to explain it in a way that anyone can understand. So I love your metaphors. That's amazing. So now that you've kind of given us a little bit of the framework, how is the cholesterol in the brain different from the cholesterol in peripheral circulation?
Oh boy. And so really it is supposed to be kept siloed from the peripheral circulation. Like I said, in the peripheral circulation, the ApoB containing lipoproteins are mailmen, deliver the mail, triglycerides, a few phospholipids, and then go home to the liver at the end of the day. And really in the brain though, it's wildly different. There are some of the same nomenclature in the brain, but the characters are vastly different. And so the half-life of cholesterol in the brain is 6 months to 5 years. Holy smokes. That's a long time. Whereas in the periphery, it's several days. And in some of the particles, the VLDL, the IDL particles, the chylomicrons, they're gone in minutes to hours. Those are quickly hydrolyzed. And then the LDL particles will linger, a few days. And HDL particles are around a little bit longer than that. But in the brain, oh, wow, the half-life of cholesterol is much, much longer. That's kind of interesting. And 20 to 25% of our total body cholesterol is in the brain. Oh, that's also interesting. And so this is why there's a lot of concern on, cholesterol and low cholesterol levels and various medications as far as brain health. And there's some nuance to that for sure. And so the brain is rather interesting. And what's supposed to happen in the brain is the astrocyte is really supposed to, in the adult brain, make the cholesterol. And then the cholesterol is exported out into something called an ApoE HDL-like particle. So we can call them basically HDL particles because they're in that density range. Are they really HDLs? No, but they're in the same density range. Whereas below the brain, our HDL particles typically have ApoA1 as the primary structural lipoprotein. Already we're getting crazy here, right? But under normal physiologic circumstances, your astrocyte, makes the cholesterol. Okay, we got some cholesterol, and then it exports it to the ApoE HDL-like particle. Then the ApoE HDL particle delivers it to the neuron, and the neuron uses cholesterol for a litany of functions, for synaptic transmission, incorporates it into lipid rafts, and it's really essential for the neuron to be able to do its work. Additionally, cholesterol production is quite costly energetically. It takes a lot of ATP and acetyl-CoA and NADPH to synthesize cholesterol. And so the neuron has a lot of work to do, right? It's busy. It's the CEO. He's doing all sorts of stuff. At a busy medical office, he could be the physician, right? And he's doing all sorts of stuff. He doesn't really want to be synthesizing cholesterol and use his energy to do that. He wants to have it on his desk, sign the prior auth and go on his merry way. And so the astrocyte is kind of like that support staff. And really at a good medical practice or at a busy office, you need everybody doing their parts in order for things to be streamlined and in order for things to work the way they're supposed to. And so that's supposed to be how it happens. However, in the context of neuroinflammation, that process can go awry. And, if the neuron isn't getting the cholesterol delivered, the neuron can synthesize his own ApoE, which is not good. And that's a sign of a stressed neuron. It can make its own cholesterol. That's a surefire sign for inevitable burnout. when the neuron who is orchestrating everything else in life is having to do the job that an astrocyte or other cells in the CNS are having to do. And you can do it for a little bit, but long-term, you're going to have some consequences. And so that's a little bit of the brain cholesterol story. And I know I teased you with a little ApoE discussion, and I'm sure that will probably follow. But lipids in the brain are pretty wild. And one thing before we get into the next adventure is ApoB in the central nervous system, right? ApoB is a 550 kilodalton glycoprotein, very big. 4,536 amino acids. So it doesn't cross the blood-brain barrier. And it's been stated for a long time that there is no ApoB in the central nervous system. Well, a couple of years ago, Picard and colleagues demonstrated that there was ApoB present in the central nervous system in certain people, and it was correlated with the presence of phosphorylated tau, which is one of the hallmarks of Alzheimer's disease. And so it can be there. It's not supposed to be there. If it's there, that's problematic. But with brain lipids, we're always learning things. And I think Aristotle said, the more you know you don't know. I think he was talking about lipids, actually. And so we're learning things every day about that, and having to sometimes shift our paradigms based on that.
Wow. Yeah. Dr. Dayspring also alluded to the fact that, even because people get so concerned to me in the pharmacy when they start a statin and they say, oh no, if my LDL is this low, does that mean I'm going to get Alzheimer's? Or, that you read different things. But from what I understand is your LDL in your periphery does not correlate with cholesterol levels in your brain. So you cannot deduce that if, you have a certain cholesterol level in your periphery on your lipid panel, that doesn't correlate anything with what's going on in your brain. Is that right?
This is interesting. And so, okay, I'm going to address this. I'm going to give you the 3 big buckets of lipid disturbances in the brain, and then I'm going to elaborate that based on what you just said about cholesterol in the periphery correlating or not correlating with what's going on in the central nervous system. So in the Alzheimer's disease brain, we consistently see 3 lipid anomalies. And at one point during my PhD dissertation, I had about 150 different ligands and proteins. And I was like, all right, what's the big important one? How can we make sense of this? Does this really have a lot of relevance? And it was crazy. But I've kind of narrowed it down in my framework to 3 big buckets of lipid disturbances. One thing we see in the Alzheimer's brain is defective cholesterol transport. Okay, your ability to transport cholesterol from astrocyte to neuron is impaired. Okay, that's one. The second is impaired ability to eliminate cholesterol. Because if there's cholesterol excess, well, we want to be able to get rid of it. And the neuron has one way to do that. He can turn excess cholesterol to something called 24S hydroxycholesterol, and that can diffuse across the blood-brain barrier and then be cleared in the periphery. So, okay, we have that decreased ability to rid ourselves of excess cholesterol. But then the third anomaly is actually decreased cholesterol synthesis. And so people that have Alzheimer's disease, even on autopsies, we see decreased cholesterol synthesis and all the enzymes related to cholesterol synthesis. And we see decreased desmosterol, which is the penultimate precursor to cholesterol in the brain. And across the board, we see decreased total brain cholesterol in people with Alzheimer's disease. And so, okay, so does that correlate with what's going on below the brain? Well, maybe is the answer. And I think that what's encouraging to me is we're having better biomarkers, we're learning more things, and we're going to be able to operate with nuance and precision in the future. And so the cholesterol synthetic pathway is a 37-step process, so many intermediates, it's ridiculous. But it starts off linear, and then you get to the final linear product is something called squalene before it aromatizes into something called lanosterol. And so lanosterol is the first ring structure because there's 4 rings on a cholesterol molecule. And then lanosterol has a couple different choices. It can go to something called lithosterol, which is the Cann-Dutch-Russell pathway. And then there is something called desmosterol, which is the block pathway. And so the block pathway actually predominates in the brain, and that's desmosterol. And then desmosterol can be converted to cholesterol from there. whereas below the brain, the Cann-Dutch-Russell pathway seems to predominate. So everything's flipped in the brain. And so Sato and colleagues actually tested desmosterol levels in people who had Alzheimer's disease and cognitive impairment in the Helsinki businessman study, as well as a Japanese cohort. And they found that the desmosterol levels in the serum actually correlated quite well with what the desmosterol levels were in the CNS. And it correlated quite well with cognitive decline. Ooh, so that's interesting. So potentially, now these studies weren't huge, okay? But at the same time, is it possible that desmosterol could be a marker of cholesterol hypoproduction and could be a prognosticator of people who have decreased cholesterol synthesis in the central nervous system and could go on to have cognitive decline? I think it's possible. And so I think desmosterol is a great test. Desmosterol and lithosterol are your markers of cholesterol production, whereas campestrol and cytosterol are your markers of cholesterol absorption. And Boston Heart Diagnostics does run those tests. And so if you have an ability to run those, it can not only give you nuance when it comes to potentially what you're seeing with somebody who has a complaint of cognitive impairment, but it can also help, I think, you operate with nuance if you're selecting lipid-lowering therapies. Because let's say somebody is a hyperabsorber at baseline. Well, that person, you might actually reach for ezetimibe, right off the bat, rather than, just go with the statin, if they have elevated campestrol and or cytosterol. So it's an interesting thing. And so basically, does it correlate? Well, desmosterol seems to quite well. And, is that the be all end all? No, but I think it potentially could be part of what we look at. It's something that I would look at when I was in clinic. If somebody was complaining of cognitive impairment and or if I was concerned that their response to typically a statin was quite robust, if I saw the desmosterol levels trending quite low, and this is not evidence-based or something, this is just biochemistry based, and Dr. Dayspring has said similar things, I would be inclined to use combo therapy, and I'm a big combo therapy fan anyway, just because the maximum, if you use a statin, the maximum, reduction in LDL cholesterol is going to be with your initial dose, and so any subsequent doubling, you're going to get, maybe 6% additional LDL-C lowering, but you're going to increase the side effects quite a bit. And I'm not big on, side effects. I think if you're going to use a tool, it's good to, maximize the efficacy of that tool without, just leading to off-target problems. And, and one example of that is, nuance of diabetes. So when you use a moderate intensity statin, let's say rosuvastatin 5 milligrams, for instance, you're going to have a 10% increased risk of nuance of diabetes over 5 years. This is a recent meta-analysis versus high intensity statin, 36%. That's a lot. That's not a trivial increase, but at the same time, how could I get better LDL-C reduction? I could upfront use, the lower dose statin plus ezetimibe. I actually get better LDL-C reduction with that combo. I minimize the side effects. The tolerability is better. And, there's a few studies over in Europe where they've used this approach post PCI, and there was some, decrease in recurrent events there. So it's interesting. I think the paradigm is also shifting to combination therapy, knowing that we have multiple ways to address this issue. If the goal is to get you living in a safer lipid neighborhood, hey, let's think about using multiple tools in our toolbox rather than just, relying on the King Kong dose of the statin. If it was 2004, absolutely, right? Because it was kind of like statins and pray. I think you should always pray. But at the same time, we've got other tools if there's a need to get you living in a safer lipid neighborhood. And so anyway, that was a long tangential thing, but it's possible that desmosterol could be a marker that correlates well serum-wise with what's going on in the CNS. Obviously, there's always things to continue to learn, and there's other biomarkers that could be helpful as well. But at the end of the day, I think it's knowing that we know exactly what we're doing below the brain with our lipid-lowering tools, knowing that there's only one of those lipid-lowering tools that does cross the blood-brain barrier, which would be the statin. I think it's just good to use those in combination until we find out who's the person who maybe we should use a higher dose statin in the brain. Maybe if they have excess ApoB in the CNS, maybe that's a person that could have statin. We don't know these things. At the population level, statins don't increase the risk of dementia. We know that. But I think that we're looking at individualized treatment and precision, and knowing a few more things about what's going on in the biomarker realm, I think is going to help us better understand what combination of therapies, if necessary, is going to be useful to mitigate people's cognitive decline.
Yeah. I'm glad you brought up the combination therapy. My dad actually went to the cardiologist last week, and they put him on a statin, which is fine. They put him on atorvastatin, and they didn't put him on high dose, which I was kind of surprised by, but also grateful for, because his hemoglobin A1C is already in the pre-diabetes range. Okay. But I questioned why not add ezetimibe with the atorvastatin. And when I questioned it, the nurse called me back and said, the cardiologist says we want to maximize the dose of the atorvastatin first before adding on ezetimibe. And so I said, well, how can I, get the cardiologist some more information or studies on the benefits of combination therapy being just as effective as high dose statins with a lower rate of side effects? So she gave me an email address, and so I sent some information over on that annoying patient. But I do want him prescribed ezetimibe with his atorvastatin with his high score. So I'm glad you brought that up. I think it's something we underutilize. And I don't know why, from everything I've read, it's all out there about combination therapy, but it's not used very much in practice. I still see 98-year-old nursing home patients on 80 milligrams of atorvastatin. And I'm just, why are we doing this to these people? But
yeah, I'm 100% in agreement with you. Outside of acute coronary syndrome, there really isn't strong data to be using, just high intensity statin monotherapy. There really isn't. And we have so many tools these days. And I'm sure you probably sent them the racing trial, showing that the combination of moderate intensity statin plus ezetimibe was better tolerated. There was less diabetes over time, better adherence, better LDL-C reduction, And so, we have a lot of data now. It's not like we're just messing around and being theoretical. No, the data's there. And I think that this cardiologist hopefully will read my book here when it comes out here in a few weeks, and
I'll send it to him.
Yeah, he'll become combophilic, because there's all this, we can talk about hydrophilic statins and lipophilic statins. Let's just be combophilic and use our multiple tools in the toolbox, because I think we can more safely and effectively get people living in a safer lipid neighborhood if they need to, since they've been broken into, without jeopardizing their home security system, right, and their quality of life, because pillar one of my home security system is normal parameters of glucose metabolism, i.e. not having diabetes, not having insulin resistance, and all that's a continuum, right? It's kind of like being, mostly pregnant or almost pregnant. No, you are, you aren't, it's just a matter of how far along you are in that process. And if we can do things to minimize, the side effects there in any way, well, why don't we do that? And we can. And I'm a big fan of, the upfront, lower dose statin plus ezetimibe combo. You get really good results. And it's one of those things where if you are living in a neighborhood where you've been broken into, your body fights you tooth and nail to stay in that rough neighborhood. This is home, darn it. And so when you use a statin and you decrease cholesterol synthesis, your body's smart and it increases its absorption. Well, how can we decrease absorption? Let's just tack on ezetimibe. Additionally, if there's a need to get people to a lower LDL-C target, well, what do statins do to PCSK9 levels? Well, atorvastatin 80 increases PCSK9 46%. What does PCSK9 do? Well, it degrades your LDL receptors. Well, you could tack on, and PCSK9 inhibitor. They all work really well together in synergy. It doesn't have to be a choose one or the other. Third-party payers will say otherwise. But from a mechanistic standpoint, from a biochemical homeostasis standpoint, the tools we have work really, really well together in combo. And it's unfortunate that too often, I think people are still worshiping at the altar of high intensity statins when we really can, I think, more smartly and safely get people living in a safer lipid neighborhood.
Yeah. I agree. So one thing you said is that at a population level, statins don't increase the risk of Alzheimer's. Is there a biomarker that can be checked that would, on an individual therapy level, say that you might have a higher risk of Alzheimer's with a statin? Is there that biomarker available, or is that not a thing yet?
I think from a lipid standpoint, desmosterol is a nice thing to run as far as, hey, are we concerned about having, decreased production, given that it does correlate quite well with production in the central nervous system. And so we can potentially use that, and we probably need just larger studies with more biobanks. There are Alzheimer's specific biomarkers that are really encouraging, p-tau 217 and the amyloid beta 42 to 40 ratio. Those have actually been demonstrated to correlate quite well with some of the imaging lately. So that's improving all the time. Substrate utilization across the lifespan is huge as far as the risk associated with diabetes and hypertension and all these, basically my home security system framework. Well, we need to do everything we can to maximize that, obviously across the lifespan for all of us. But I think that what is something that we probably ought to know is our ApoE genotype. And I think that can help us also act with some nuance. And I think that's probably a good segue into ApoE. And so ApoE below the brain is 60 to 90% of HDL particles have ApoE on them. And then ApoE can be transferred from HDL particles to ApoB particles. And what ApoE does is it's kind of an access card to the liver. So if a particle has ApoE on it, it's going to, an ApoB particle has ApoE, E for easy access. The liver will readily uptake it, and it will help clear the lipoprotein under normal physiologic circumstances. All right. That seems fine. Now in the brain though, ApoE is the predominant cholesterol particle that's delivering cholesterol from astrocyte to neuron. So you and I, all of us, we inherit one copy of ApoE from each parent. So ApoE gene is on chromosome 19, and it's actually really close to something called ApoC1, which is another interesting lipid character that we haven't quite figured out what to do with. But anyway, so ApoE is on chromosome 19, and so most people have two copies of what's called ApoE3. So the wild type, which would be the most common type, would be a 3-3. So 75% of people have a 3-3. And then about 14% of people have one copy of ApoE4. And then about 2% of people have two copies of ApoE4. And the most well-known person who is a homozygote for ApoE4 is Chris Hemsworth. So ApoE Thor, maybe, since his character that he plays in the Avengers. And so anyway, but yeah, so he has two copies of ApoE4. And so people with one copy of ApoE4 have about a 3 to 4-fold risk of Alzheimer's disease at baseline, no other factors being considered. Whereas people with two copies of ApoE4, maybe about 12x. Ooh, okay. So now here's the thing. And then there's ApoE2, which isn't as common, and that's a different conversation, more relegated for lipid geeks who want to talk about type 3 beta lipoproteinemia, which we can if you want. But anyway, but it's really the ApoE4 that has been identified as the number one genetic risk factor for Alzheimer's. Outside of the autosomal dominant mutations in APP and presenilin-1, those are really rare, really accelerated early Alzheimer's, and that's really, really rare. But for the general population, ApoE4 is the number one genetic risk factor. Okay, so I think it's useful to know. I mean, that doesn't change. I think it's good to know your ApoE genotype. This used to be contentious. People would say, well, I don't want to know, but it's not a deterministic gene. This isn't like, Huntington's disease, like where it's like, okay, if you have this allele, you're going to end up with this horrible, neurodegenerative condition. But it tells you that you have less margin for error. And I think I would want it. I mean, I do know. Thankfully I have a 3-3. Okay, not interesting. My wife though has one copy of ApoE4. Okay, good to know. So I think that here, if your fire department is defective, so to speak, well, just don't let fires start. Is the best way to go about this. And be preventive. And it just tells you, hey, I have less margin for error when it comes to, actually metabolic health. And I would say things like, alcohol usage and things along those lines that, is not going to be probably as critical to be quite as Spartan and monastic if you have a 3-3 copy or a 2-3. Whereas when you have a copy of ApoE4 or 2 copies, I think you have less margin for error, because the last thing you want to do is in your terminal decade, just not be you anymore. There's a big difference between living and existing. And my grandmother just passed away from Alzheimer's, and it's super sad. It's super, super sad. And, for as long as the good Lord keeps me around, I want to be crushing it cognitively and then be done, and I think that would be the case for anybody. And so I really do believe that, getting ahead of the game for all of these things, whether it be cardiovascular disease, whether it be brain health, is of paramount importance. And I think that, just knowing your ApoE genotype is a useful thing to know.
Yeah, I agree. So I do a lot of pharmacogenomic testing for patients. And so I've tested probably 250 patients now. And I'm an E3, so thankfully. But I do have a handful of patients where I've tested. They do have a copy of the E4, and I do have also a handful that have 2 copies of E4. Interestingly, most of the patients that are 2 copies of E4 are in a dementia unit of a nursing home. So it's been interesting that way. But I have worked with people in the community who have E4 too, and I do tell them, it's important to know and then mitigate those risks. And one of the risks, that you mentioned is insulin resistance. So I want to ask you this, because in the community, I see a lot of patients with diabetes. If their A1C is in the pre-diabetes range, I don't see a lot of providers treat that. I just see them monitor it, and then they end up getting, diabetes after some time. But would it help mitigate the risk if a person with, a pre-diabetes A1C was started on a metformin or something to prevent the full-blown diabetes? Would that also reduce their risk of Alzheimer's?
Yeah. And so I think that, if you're trending in the wrong direction when it comes to insulin resistance, nobody ever said, boy, I wish I was more insulin resistant. Boy, I wish I had more glucose excursions. And I mean, glucose is critical, and in the brain in particular, right? If you and I just didn't eat for 3 or 4 days, our blood glucose would be around, 60 to 70. Why? Well, hepatic gluconeogenesis, and you have a GLUT1 transporter to passively diffuse glucose into the brain. The brain is an incredibly important substrate. Now, can it use, ketones? Yes. Can it use glucose-derived lactate? Yes. But, glucose is money for the neurons, and you need it. And so the more efficient that you can be with your substrate utilization, with your ability to utilize glucose, the better off, right? Fatty acids are your savings account. And below the brain, we should be using our savings account. But unfortunately, glucose, which are dollar bills, people are way too reliant on the dollar bills. And half the time, they don't even use the dollar bills. They're fumbling around in their wallet and dropping it. That's insulin resistance. And so if we can be efficient and utilize our savings account, withdraw from our savings account most of the time, below the brain, we can preserve the dollar bills for the brain. And then I don't think we're going to have those neuroinflammatory fires start. And so I'm all for getting ahead of the game. Prediabetes and diabetes, to me, are really the same entity. It's just a matter of how far along you are. Even before that, I'm a big fan of getting a fasting insulin, and a HOMA-IR. So if you get your fasting insulin, you multiply it by your fasting glucose, divide by 405, you get what's called your HOMA-IR. And if it's over 2, you're real insulin resistant. We need to do something about that. Additionally, if you really get granular with advanced lipid panels, you can identify insulin resistance even prior to, having a fasting insulin be elevated. My wife was a good example of that. And so she had a lot of small dense LDL particles, which there are rare genetic exceptions that will make you have elevated small dense LDL particles. But in general, that's a sign of insulin resistance. Jerry Schulman at Yale has done some really elegant work showing that the first site of insulin resistance is skeletal muscle. And so she wasn't exercising at the time. After 3 months of just exercise, combination aerobic resistance training, her overall particle count dropped from around 1,300 to less than 1,000. And her small dense LDL particles, which were elevated, completely normalized. And that was without any really shift in her diet. She was still eating way too many dino chicken nuggets, I think. But, she was just, that's the magic of movement. Motion is lotion, movement is medicine, whatever you want to say. But really, that's where insulin resistance starts, is skeletal muscle. And so that's why I think that for prevention purposes, I mean, there's nothing like exercise. And there's so many different mechanisms as far as, increasing brain-derived neurotrophic factor and increasing hippocampal volume and, all these other things that have been associated with decreased cognitive decline. But probably more than anything, it's just substrate utilization. You're using your fuel efficiently, because when you're not using your fuel efficiently, you're asking for trouble. And most of our chronic inflammatory conditions in our overnutrition society is just due to excess visceral adiposity, and this is an interesting topic as far as inflammation, right? Inflammation, it's better to not be inflamed, right? Nobody ever says, boy, I wish I was more inflamed, But inflammation, it's important to get to the root cause of inflammation. And in most people, so certain people have RA or Crohn's, there's, some of these systemic inflammatory conditions. And if you have, right lower quadrant pain, and you weren't previously having that, well, you have appendicitis, and that's why your CRP is through the roof, so go get that taken care of. But at the same time, most people who have an elevated hsCRP, which is our most common, widely available, biomarker for inflammation, and it is an independent risk factor for cardiovascular disease. Well, why is that? Well, it's generally because of angry fat. And so, if we can do something about that, which is regulate your insulin sensitivity and restore your metabolic derangements, we're going to see a nice reduction in that hsCRP. And one of the things that's really cool about the incretin therapies, right? The GLP-1 receptor agonists and, things like tirzepatide as well. They actually take your macrophages and shift them from an M1 pro-inflammatory phenotype to an M2 anti-inflammatory phenotype. Even your macrophages it's important for them to utilize fuel appropriately. So M1 pro-inflammatory macrophages are over-reliant on glycolysis, the dollar bills, whereas M2 anti-inflammatory macrophages are reliant on fatty acids for their fuel. Fatty acid oxidation is their predominant fuel source. And so what those agents do is they shift your inflammatory cells from a pro-inflammatory one to an anti-inflammatory one. And that's why it was great to see my patients who had elevated hsCRP, after we would use semaglutide or something like that for a few months, and they had, they were feeling great, they're crushing it at life now, their hsCRP would go down significantly.
Wow.
And that's really cool. And the same thing does happen in microglia. And one of the things that happens in microglia, the immune cells of the brain, is that they get really, really annoyed. Especially when your fuel isn't being utilized properly and cholesterol isn't being transported appropriately, microglia become reactive and they become pro-inflammatory. And there's some preliminary data, I think they still need to tease that out, on the same sort of thing happening with those GLP-1 receptor agonists, even in the microglia. And there's some real benefit that's being shown in the neurovascular unit with those agents too. So could that be part of a cocktail for metabolic and lipids for mitigating cognitive decline? I think it's possible. And so it's all about substrate utilization and getting to the nidus of inflammation, rather than just, let's all take ibuprofen for, both cardiac disease and dementia prevention. Well, probably not. And another example of this that I think that the context really matters with inflammation is this people group called the Shimane in Bolivia. So these guys, they're hunter-gatherers. Their baseline hsCRP mean is 9.2. Holy smokes, right? Anything over 2, I mean, that's independent risk factor for cardiovascular disease. Oh, shoot, 9.2? So you must think, oh, these people have raging heart disease. They don't have any heart disease. Why do they have elevated hsCRP? Because they're riddled with parasites. And so it's a matter of, okay, if you have inflammation, why is it happening? A lack of inflammation, you're going to be susceptible to all sorts of infections and things. These people, they live in an area where the water isn't very good, and they're riddled with parasites. So that hsCRP, which actually has a pentameric and a monomeric form too, which we can't blood testing, interestingly, their CRP is just eradicating parasites. Good for them. And fascinatingly, even people with ApoE4 copies tend to not get Alzheimer's in the Shimane. And it was actually, there's one 2017 study where they did cognitive testing on them. And it was actually the ApoE4 people that actually had better scores in that population. So once again, it's context that matters. I think when your body resents its state of chronic overnutrition, then yeah, ApoE4 becomes really, really meaningful, super, super bad news. You have less margin for error. However, in the context of appropriate substrate utilization across the lifespan, I think that, your genes are not your destiny. Kellyanne Neotis, who's brilliant, you should have her on the show. She's a preventive neurologist. She's absolutely fantastic. I've never met her in person, but I've listened to her stuff. She's brilliant. But she says your genes are not your destiny. I 100% agree, especially when it comes to cognitive health. And I think that anything that we can do to maximize our parameters of glucose metabolism, honestly, the home security system framework in my paradigm, and then also looking at all the other factors as far as your lipids and making sure we're getting ahead of the game on cardiovascular health is essential. And I think if we really take this same preventive approach across the board, we're going to see a huge decrease in not only coronary disease but also in Alzheimer's disease and other types of dementia.
Yeah, I'm glad that you end with giving everyone hope, because I do feel like when we talk about dementia, when we talk about Alzheimer's disease, people feel like the outlook is kind of bleak. But the way you said it is you feel that it's hopeful, and you want to make sure that our listeners have hope also, that we're knowing more and more about Alzheimer's all the time. And there are things that we can do to prevent Alzheimer's that you allude to in your book, the home security system, including blood pressure control, decreasing insulin resistance. What were the two other ones again?
So my home security system has 4 basic pillars: normal blood glucose, which is parameters of glucose metabolism, not being insulin resistant. Pillar 2 is normal blood pressure. Pillar 3 is keep inflammation low. And that's, and now you're like, well, what about the Chimene? Well, they have a good reason to be inflamed, and they have perfect glucose metabolism. So, But, and then pillar 4 is don't smoke or do drugs, because those are bad. And so, and those are part of, there was an article that came out last year that was like the 14 modifiable factors for Alzheimer's disease. And, 3 of them were diabetes, obesity, and physical inactivity. Well, to me, that's all, hey, this is all substrate utilization, right? And those are all inextricably intertwined there. Alcohol was in there as well, excess alcohol use. And, that's a neurotoxin. And, I would say that the right amount for just optimal physiology, is 0. But anyway, that's another conversation. That's in my book too. And I have some good rationales for that. Not just trying to ruin people's lives. And then, elevated ApoB, elevated LDL-C in midlife has been shown in several different studies as a risk factor as well, although the lipid picture is complicated, right? And that's why it's one of those things where one of the things that people say a lot is, cumulative exposure to atherogenic lipoproteins is like plaque years, whereas pack years of smoking, you don't just wait around to get lung cancer. You should stop today. They say that that's the same sort of thing as far as, LDL cholesterol. If you have LDL cholesterol your whole life, well, that's like exposure. For a lot of people, I would say that tends to be true, but I also don't think that fits quite as well as my home security system and lipid neighborhood. All right. Because you have people, with sky high LDL cholesterol levels their whole life, and they get 0 disease. Why? What's protecting them? Right. And so it's a little more complicated picture, knowing that LDL cholesterol itself is not, in my view, inherently toxic. All these ApoB lipoproteins, they're mailmen, right? Well, mailmen go deliver the mail and then, go home at the end of the day. That's great. Maybe you just live in a really busy urban area, with a lot of mailmen around. Okay. And so I think that, now a lot of people who have elevated lipids across their lifespan, they get broken into. And if you have really, really, really elevated lipids like homozygous FH, you're going to get broken into regardless of your home security system, right? But at the same time, there's a lot of things we don't understand. I think we need to study the people who have, an LDL cholesterol of 200 their whole life, and they have a CAC of 0 and they live to be 108. Let's study those people. Let's get their genome sequence and say, hey, why are you so awesome? And then we can learn some more things, because lipids are really humbling. And, like I said, the more you know, you don't know much.
Yeah. Well, thank you for sharing with us today. And I'm certain listeners are going to want to know where to find you. Do you have a website, LinkedIn, and then where can they find your books?
Yeah. So I do a lot of posting about various lipid related topics on X, formerly known as Twitter, at Josh J. Wageman is what it looks like. Wageman. It's Wagman, but that confuses people. It's like, why is that E there? That's a good question. So anyway, so at Josh J. Wagman. On Amazon.com, if you just Google, or not Google, just search the home security system and the lipid neighborhood, my book, which releases February 18th, will pop up. Unfortunately, pre-order is only available for the Kindle version, for the ebook. If you like that, that's great. But February 18th, if you go and you want to read some stuff about this and you found some of the stuff in here interesting, then you can go on February 18th and order it, and then it'll be at your house within a day or two. And it's, my goal is not, the goal with this is just to be a resource to just help people find the signal amidst the noise when it comes to metabolism, when it comes to cholesterol, understand how it's supposed to work, understand what can happen when it doesn't work right, and understand what potentially to do about it. And so it's, the ebook's like $9.99. I anticipate the paperback will be like $14.99. So it's not going to, set you back a whole bunch. And so that's my goal. I just want people to read it. And I want to, help us overall, whether you're a clinician, whether you're a non-clinician. I want to shift the paradigm from reactionary to prevention, and I help people add life to their years.
Yeah, exactly. Like you said, you want to stay cognitively sharp and just be awesome.